Hi, this is Dr. Artie Kavanaugh, and I'm happy to join you here on RheumNow. The topic of this discussion is difficult to treat rheumatoid arthritis. An interesting topic, and it's hard not to harken back to the Judge Potter Stewart said in 1964 in the case of Jacobus versus Ohio. He said, I may not be able to define it, but I know it when I see it. Of course, he was talking about movie pornography, but I think that's the way a lot of rheumatologists feel about difficult to treat rheumatoid arthritis. I don't know how to define it, and people are starting to think about defining it, but I certainly know it when I see it, and I think that's the way most of us feel. What is difficult to treat rheumatoid arthritis? Well, I think we could flip that around and say, what is easy to treat rheumatoid arthritis? Fred Wolf said that about fibromyalgia years ago. The ACR asked him to give a presentation on difficult to treat fibromyalgia, and he said, I don't know how to treat easy to treat fibromyalgia. I think for our rheumatoids, we're blessed with such a large number of therapeutic options these days. Back in the day, we had gold injections and sulfasalazine and that new drug methotrexate, and that was it. So a lot of our patients were difficult to treat. We didn't have many options. Now we have lots of options, but we still have patients where we're not achieving the goals. And of course, the more therapies that we've had, the higher the goals of therapy have become. Indeed, we want remission for all of our patients. How many patients do achieve that? How many easy to treat RA patients? I don't think it's that many. I think maybe 25% of patients. And easy to treat to me means you get on their first drug, rarely hydroxychloroquine, more often methotrexate, sometimes methotrexate and a TNF inhibitor, sometimes other mechanisms, and they do great. They don't have synovitis. They come and see you, and their checkups are quite easy. They're tolerating the medicine. But that means the rest of the patients are difficult to treat by definition. What makes them difficult to treat? Well, I think many of us would agree from an immunologic standpoint, there are patients who have persistent synovitis, and we've given them good tries of many medications, and they still have persistent, abundant synovitis. Those people, seropositive in general, often with extraarticular manifestations, have been on therapy after therapy. There's no particular number to me that says it's difficult to treat rheumatoid arthritis, but we know that there are those patients out there. But I think that's a smaller subset. The difficult to treat is more of a complex construct to me than just that immune construct. I think it has to do with a lot more of the doctor characteristics and the patient characteristics. Certainly, we work with our patients. We don't prescribe drugs to them. We give them choices, and we work with them to pick the choices. And we all know that there are patients who have difficulties with medications. I think my heart sinks if I read a chart for a patient I've not seen before, and they're allergic to 20 different medications. I know that the chances I'm going to find a medication that they've not been on that's going to work are going to be relatively small. And I've also learned over the years for our younger viewers, back when I was young and knew everything, I would often engage the patients and say, well, this shouldn't make your teeth itch. I don't know that I've never seen that before. It doesn't matter. If they think it makes their teeth itch, they're not going to take it. We're also frustrated, I think, difficult to treat when we see charts where patients have been on one medicine after another, and perhaps only 1 or 2 months of a trial. In that case, I'm not sure that we would define that as a failure. Still, the patient is difficult to treat. A big issue is the compliance with medications. And when I have younger trainees, sometimes they'll wonder what's going on. Why do I ask the patient 2 and 3 times about the medicines that they're taking and what day they're taking it and what does it look like? Because there's no medicine that's going to fail like a medicine that the person is not taking. So compliance or having the patient actively participate in the choices is super important. So to me, this is why difficult to treat rheumatoid arthritis is such a tough issue, because it involves potential immune contributions, doctor characteristics, and patient characteristics. We have lots of choices, but we still have patients that we need to do better with. Thank you.
Hi, I'm Jack Cush with RheumNow, talking to you about my approach to difficult to treat RA, D2T-RA, as it is known in the biz. You already saw Artie Kavanaugh's great video where he talked about considerations. And I like that he gave you a big piece on considerations instead of, all the new molecules, all the future therapies and whatnot, because I think he and I both believe that while those could be an option for some people, they're not the answer for the majority of people. Difficult to treat RA is a complex thing. It encompasses a lot of different kinds of patients. And he said, I know it when I see it. There are definitions of D2TRA put forward by EULAR. The lead author was Nagy. My book talks about this. It's basically failure of two or more biologic or targeted synthetic DMARDs after having tried a conventional DMARD, and that there's signs of activity, either with moderate disease activity, signs of active disease, inability to taper steroids, radiographic progressions, RA symptoms, and poor quality of life, and that the patient and doctor both agree that this is difficult to treat RA. I think that my easy definition of D2TRA is it's when you cross that threshold of diminishing returns. The patient's been on 2 or 3 or 4 or 5 conventional oral DMARDs. They've been on more than 4 biologics. Giving another biologic or the drug you've never used, you really think that's going to work? It's not. The prevalence of this problem is large. In most large series, population series in your practice, it's about 10%. And that's a number that's shown up in 3 different studies. Dr. Kavanaugh was right. I think about 25% of our patients are easy, right? And then 10% are really difficult. And then there's another 60% who we struggle with, but you're pretty good at managing. And that's where you're expert. But it's these difficult to treat RA patients that are a problem. The problem is that there's no guidelines. Now, good, EULAR has a definition, and now we're starting to see studies that are evaluating different approaches and considerations. But if you look at the EULAR and the ACR guidelines from 21 and 22, nope, not really even addressed. The markers, the clinical features that characterize this population. They're older, they smoke, they're obese, lower socioeconomic groups, lower inadequate levels of education, many joints, nodules, vasculitis, acute phase reactants, high titer, ACPA, NRF, radiographic erosions. They may or may not have the genetic shared epitope. But again, that's really not, for me, the things that really characterize this population is not adherence to therapy, coming late into rheumatologic care, meaning a whole lot of damage was done before you ever got them. Bad genes, bad behaviors, wrong diagnoses. You're wanting to wean down their DMARD therapies. What are you thinking? The quest for monotherapy, equally nonsensical. The failure to change therapy, that's often your fault. And just flat out guessing about what to do next. You're now in the category. I'm making this easy for you. It's either the wrong diagnosis, the wrong drug, the wrong patient, or the wrong doctor. Wrong diagnosis. Consider the diagnosis. Misdiagnosis of RA happens, especially seronegative. Study of 435 seronegative patients showed that only a third of them went on to develop another diagnosis. Wait, no, I'm sorry. 2/3 of them went on to develop another diagnosis, with half of those being PMR, pseudo-gout, osteoarthritis, and one of the seronegative spondyloarthropathies. But misdiagnosis is a frequent cause of what you're calling RA and ain't RA. Here's the features that unify these people. Think about this. Often seronegative, more atypical presentations, longer time to diagnose, more DMARD failures, more biologic failures, more drug toxicities. Big red flag for each of those that you're dealing with another kind of patient and maybe the wrong diagnosis. Wrong drug, that's always a big thing. I'm shocked at the number of rheumatologists who have tried 7 biologics and haven't tried the 2 or 3 remaining, who still want to try the 2 or 3 remaining even though the patient failed everything in the past. I'm sorry, the patient's screaming, I'm not RA. Don't give me an RA indicated biologic. My approach to therapeutics are consider other diagnoses, as I said, and the other things I'm going to say after this. If you really want a diagnostic approach, look at the blog I wrote on this called Difficult to Treat RA, where you take the Control-Alt-Delete, meaning what drugs previously controlled the patient, prednisone, Enbrel, whatever. What drugs do you delete that they would never take again because it gave them itchy teeth? They're never going to take methotrexate again. They're never going to take leflunomide again. They're never going to take whatever it was, cyclosporin again. I don't care what the reason is. You don't fight them on stuff that is in their head. The story they're telling themselves is that drug doesn't work. And then the alternatives are the things that you haven't yet tried and you could try a lot of different things. And again, I have my own list that's a little odd. You may have your list, but for instance, I like to use in difficult to treat patients JAKs, rituximab, and weight loss, including bariatric surgery. Lastly, you get handcuffed on the wrong drug based on their side effects and comorbidities. Knowing what drugs you can safely use is the way to go there. If you don't know, ask someone else. I don't use experimental drugs, bortezomib, tacrolimus. I only use once. Vagal nerve stimulation, GM-CSF inhibitors, BTK. No, but I do use sometimes anakinra, gold, cyclophosphamide, cyclosporin, mycophenolate, apremilast, and IL-17. What, really? The latter three in patients who are seronegative. Lastly, the wrong patient. They're non-compliant, won't go, can't show, can't do, no shows. That's their message. Negativistic thinkers, diabolical negativism. I wrote about this. Poor patient managers, poor sleepers, people with anxiety, depression, chronic pain seekers, the vaccine-nots, magical thinkers, and different drummers. These people are hell on wheels. There's a lot of underlying depression, psychiatric, psychological disorders, and fibromyalgia. Deal with it, because giving them a biologic is not the solution. And lastly, the wrong doctor. Don't be afraid to get a second opinion. When you've done all you can do, admit it, send them to your best buddy across town. So checklist. Ask the patient what they want. They'll tell you what they want. Use a team approach. If you're unsure about the pain, and it could be mechanical, do imaging to get to the bottom of pain, to find out if it really is inflammatory or it's mechanical. Deal with depression and bad behaviors. Don't be handcuffed by safety limitations that you don't understand. Ask for help, right? Reboot the system. Control, Alt, Delete. And then rethink the diagnosis and get a second opinion. This is my approach to difficult to treat RA.